So we go to the next case. Again, this is a very open forum, and we would like all your comments coming up at this stage. This is how a full atheropath would believe. You can see the typical Indian coronaries, as we call it, thin vessels, diffuse disease, you would struggle, surgeon would struggle, everything very difficult. But this gentleman also has aortogram, which is very, very striking. We have critical disease on the right iliac and a total obstruction of the left iliac. Left iliac, however, you see the reformation and the distal vessel beyond the internal iliac. That looks very good, and it's a fairly clean distal vessel. So you have sort of a disease which is limited to origin of the iliac and onwards in this. In addition, this patient had bilateral critical carotid stenosis. He had history of a TIA nearing 5 years back, but no symptoms in last 5 years. So that TIA was from one of the carotids, and the other carotid was asymptomatic. I will show you in a little while. So this is a typical atheropath, so we decided we'll fix the carotid and the iliac percutaneously, and then hand it to a surgeon for coronary revascularization. So we come in from the groin. We have 2 sticks from both sides, and we come in with the Teremu wire, which is subintimal, could not be advanced into the aorta beyond this point. Then we come in with Aquatrack. You can see the lower end is an Aquatrack wire. Again, not making any progress. So at this stage, you saw Dr. Khanna showing a radial approach. So we thought we should come in from the right radial. So we come with a right radial approach with a catheter there. And we decided we will come in with a coronary wire. So instead of taking any of the regular wire which we take for peripheral CTOs, this is a coronary wire. The good part is it looped fairly early as we were trying to advance. And as we pushed it, the loop continued to go forward, as you can see on the screen. No resistance and a fairly easy track. So this is one way you might probably stay in the true lumen if it is going easily. And so we go to the sheath. We sort of pull it out towards the sheath. But it got stuck at the valve of the sheath. It could not come out. You can see in the next frame, you have the wire not coming out through the sheath. So we decided we'll pull the whole sheath out. So this is, mind you, an 014 wire, and we clamped the sheath with artery forceps, hoping we also grasp the 014 wire. And we pulled the whole wire, maintained pressure with the fingers on the groin, and introduced a 4 millimeter catheter over 014 wire, and that sort of held the bleeding. We continue to work from the top as of now. This is a 014 wire. We have multiple exchange of balloons. You can see another balloon being brought in. And we now sort of are advancing the 4-French catheter from below and withdrawing the arm catheter at the same time. Mind you, all on 014 system. It's a little bit tricky. Maybe it may not succeed every time, but I think we are doing reasonably good at this stage. So this is 014 supporting us. And once we have 014 in position, we put a 3-5 wire through that, remove the 014 system. We have a sheath on this 3-5 wire. So the groin is more or less steady. You have dilated the iliac on both sides. We have good flow, and the groin is ready. So we now bring in 2 stents from both sides. This is again smart control by Cordis. 980 on the left, 960 on the right. Now, Michel, the issue is, do we cover the lower portion of the aorta? I think whenever you have come to our lab, we always felt it's good to stay a little bit inside, a few millimeters inside the aorta, because it would be unusual to have typical iliac ostial disease. There would be some disease in the upper portion of the aorta. And this is what we felt. You agree?
Okay, but one question. You had a failure by retrograde approach on the left side. Why you didn't do a contralateral approach from the right? I think that's the best option to treat an iliac occlusion, the contralateral side approach. What do you think? No, radial, it's a good way. Radial, it was perfect, but you are on the right side with the catheter, so you can continue to change your catheter.
I think this is a learning that we should have come contralateral right in the beginning. I think once we tried ipsilateral, we have flaps, we have dissection, so going through contralateral would have been difficult. No?
No. It's the same.
Four is not that enough from the, so we, like this, if I have to start, I will not start even retrograde. I'll put only seat, not the wire. I'll put from the antegrade, from the brachial artery straightforward. All CTO, IVX start from brachial. This is my principle. All aorta, 100% blocked, low renal, start from brachial. This is my philosophy.
Everybody agrees, Dr. Khanna. Can we have the lights on at the back? I mean, it was quite nice to have some light at the back.
I think, what I would have done is left this wire which went subintimally on the left side and tried with another wire from the contralateral side. So that we know where the subintimal plane is and we go into a different plane in a different view. And normally I would do the same and I cross CTOs first through a femoral approach or a brachial approach. Because it gives you a much better pushability if you can get to a true track. And you can manage better.
Michel, what do you think? I mean, if you go from the same side as we went in the beginning, you have more force because you have a very short segment to cover.
Yes, you have. And you take, for example, a sidewinder or a type 1 or internal mammary catheter, and you can direct very slowly and in at least 95% of the cases, you reopen your artery. But it's not 100%. But it's the same as for bibrachial or radial approach, it's the same.
But the brachial approach do have more support compared to say contralateral side. You do have a good sitting of the catheter across the occluded CT of the left iliac, and then you can push very well the wire while going via the contralateral. You are not going to have a good support because your catheter has to take a curve across the bifurcation of the aorta.
Yes, I agree with you if you have very calcified lesion. But in that case, I think it's not very calcified, so it's smooth artery. But I agree with you, for calcified lesion, maybe I will have crossed by radial or humeral approach. But in that case, with smooth lesion, I don't think it's a big problem. With calcifying, it's sometimes difficult, yes.
But I feel personally that such type of lesion do need a 3 approach, right femoral, left femoral, and also the right brachial. You can be successful from one side, may not be then contralateral, and in case you are not successful, then via brachial. So
left brachial. So left brachial is better or easier than right brachial.
Yes.
Yeah. So you can see the two stents. The top of the stents must be well aligned with each other in the iliac. This is going to be a simultaneous deployment, so 2 operators, and they must coordinate very well to start sort of deploying the stents together. Now the whole thing is done on we are not injecting contrast. It is already there, and we are using the frames just to see where you are. And you deploy the stent. You can see the 2 stents touching each other. The initial portion has to be very gradually deployed. Once you're deployed a few millimeters, The subsequent deployment would be easy. This is a post-dilatation with a bigger size balloon. And this is the final result.
What you can discuss is the use, which tend to, it's a 19-hole, self-expandable. What we could discuss is maybe cover stand. Is it the same price?
Yes.
What do you do? Cover stand or a 19-hole stand for this kind of lesion?
Probably covered. Yeah.
But the study, Australian study, showed better result with cover stand.
The last couple of papers that I've heard presented have all gone to covered stents in this area where they've had really severe disease and when it's been occluded.
But it's 3-4 times, 5 times the price of 19-hole stand in India or too. No?
Covered stent, I think it's about 1.3 times the price of the regular stent, right?
Just 1 point.
Yeah, 1.3, 1.4.
I might just add that the Endologics company is, I think, going to make a device, a unibody device that's only 20 millimeters of body that'll sit on the bifurcation that they're going to market for a very low price, something very competitive to putting in three stents.
Mm-hmm. So there have been occasions when we have put balloon expandable stent in the lower portion of the aorta and then come in with 2 self-expandable stents like this because at times the lower aorta is very heavily calcified and it may not be possible to get a good expansion with the self-expanding stent of this nature. So in this particular case, since there was not too much calcification, we use this approach. Otherwise, our approach would be like a pajama stent, balloon expandable stent in the lower portion of the aorta, generally a Palmard stent, and then 2 legs coming with a 19-hole stent. But we do make it a point to cover the last few millimeters of the aorta, whether you see a disease on the aortogram or otherwise. And we do the carotids with an 8-French guide. I think as an intervention cardiologist, I find usage of guiders so much easier than putting sheets. And actually, Michelle, we went through that phase when we were using sort of dilators and the sheets for carotid, then switch back to guiders. Michelle, you're using all guides for carotids?
Always guided there.
So a fairly simple lesion. This is angioguard 7 millimeters going through the narrowing. Then the direct stent. You can see stent in position. Most of the time, we like to do direct stenting. This is a post-dilatation, a step which is generally considered a little risky. But we generally like to post-dilate. What do you feel all about post-dilatation on the...
I post-dilate any lesion because I don't predilate in 90% of the cases, so I have to post-dilate.
So we got a good result on the one carotid, the left, and this is the right carotid. Now the issue is whether to do both carotids in one go or we stage. I think the general thinking has been never do 2 carotids at the same time. But I must confess this gentleman had come to us after 3-4 months of having been diagnosed with an atheropath, and this is only because he was retiring the next morning, and he told me that there is no reimbursement for him next morning. The other issue is reusage of angioguard. I think again we used sort of closed the angioguard and brought it back on this side, and it was possible to put the same angioguard. Fairly simple steps again. Stent in location, post-dilated, and a good result. So in short, we had bilateral iliac and bilateral carotids done on this gentleman. It was the longest procedure, but as I told you, we had reasons to do it in one go on this particular case. Anybody would have done it differently or any comments? Dr. Khanna, you have done some bilateral carotid stenting. Actually, our experience on bilateral carotid stenting done simultaneously stands around 11 cases. And we thought it was reasonable occasionally to do both together.
The unique problem is the patient is not well controlled blood pressure. But if the patient is well controlled, you can do with not a lot of risk. I did 20 patients like that without any problem. So if you can wait, maybe it's better. But in that case, if you are well controlled, I think you can do to avoid. The problem is hyperperfusion syndrome, which could happen after the procedures.
So in short, we would like to say that we are not recommending bilateral stenting, but may be done occasionally.
Occasionally, in that case, if the patient is not reimbursed, that's maybe one reason. But in emergency, when you get patient and a coronary patient, for example, you have to refer to the surgeon, it's difficult to leave a patient with one carotid stenosis. Maybe you do one when the right or the left, and you have also to treat the other side. So I think for this kind of patient in emergency or like almost emergency group, you have to do that.
Dr. Khanna, oh, yes, Vijay.
Dr. Henry, my question is regarding type D aorta-iliac disease and long-term patency of self-expanding stent. As your comment was about putting a covered stent, what do you feel that the long-term patency of covered stent is going to be the same as compared to self-expanding stent? Vis-a-vis comparison, say, of aorta-iliac bypass grafting.
You speak for carotid? For carotid or for...
Like in this particular case, when two self-expanding...
You're talking of iliac, right?
Iliac or carotid?
No, I am talking about the iliac, type D aorta-iliac disease, and putting a self-expanding stent like Dr. Hiramat has done, and most of us do go ahead with the self-expanding stent. Your comment was about putting a covered stent across the iliac. So regarding long-term patency of the covered stent, which seems to be somewhat lower compared to self-expanding stent, and of course it's lower compared to aorta-iliac bypass.
Yes, for iliac artery, there is an Australian study, I don't remember the name of the study, maybe you know the name of the study, it doesn't matter. The results are better with cover stent for iliac. Iliac in any group, type A, B, C, D.
And only if it's a total occlusion that you've recanalized. There's nothing wrong with bare metal stents for stenotic lesions, and I've done them, I do them all the time. But there's some data, I've seen two papers presented now from respectable investigators that have shown that if you put covered stents where you recanalize a total occlusion, they do better. The restenosis is much lower, because the restenosis is about 60% if you put a bare metal stent in a recanalized vessel. And
You
so
had some comment?
And for carotid, I don't recommend cover stent for carotid because there is a study also, a small study, I don't remember the exact number, but less than 20 patients treated with cover stent, and the complication rate was very high and a lot of thrombosis, maybe 20% of thrombosis in carotid. So I think except aneurysm, I don't recommend to place cover stent in carotid. Do you agree with that?
Yeah, I mean, I have never put one, but my feeling was just as in coronary, if you have a heavily thrombotic vessel, we put something like an M-guard stent. Even for carotid, is it a recommendation to put covered stent if you see a big thrombus spurt? No? No. Mm-hmm. I mean, the feeling is as you expand the stent, you'll probably be able to hold the thrombus at that local site and there will be no distal embolization.
No, if you see a big thrombus, I think that the surgeon is better. No. Yes?
Get your knife out.
Yeah, Dr. Khanna, you had a comment?
Yeah, I mean, I would, for the carotids, bilateral carotid, normally we would not do, but if the patient is young, I mean, not very old, did not have a old infarct, and there was no history of blood pressure. Sometimes we have done it in acute settings and results have been okay, but if at all we can avoid, we should. Covered stents in carotid, I put 5 or 6, but they were not for de novo stenosis or thrombus, but it was mainly for aneurysms, which I didn't find any problem, but I don't have a data, long-term data, neither I have it in literature on a series where carotid covered stents are covered with a bare metal, I mean, self-expanding stents.
But
And definitely for diffuse iliac disease, I prefer putting in wire bands or covered stents.
But I think it might evolve, and we would all start believing that if you have a heavy thrombus in the carotid, covered stent could be a good option, I feel,
Could be, but
long-term patency.
Yes,
Can you-
Dr.
We at Madras Medical Mission, we have also done 6 cases of bilateral carotid stenting at the same time. But they were all for patients who also had critical left main and had to go for surgery immediately.
But
And
the results were good?
results were good. And
The
what
risk-
would be your strategy if you are sending them for CABG? Like about the antiplatelet, what to do?
The risk you run of doing bilateral high-grade carotid stenosis at the same time is reactive cerebral hyperperfusion. And I've seen in my career 2 people bleed into their head 2 or 3 days afterwards and end up with a very bad outcome as a result of that. And I think the literature would support not doing them together, but staging them.
All right.
Unless you absolutely had to.
Thank you indeed for participating in this so-called live inbox, and appreciate all your comments and your help in presenting these.
Excellent presentation. Thank you very much.